Good afternoon, everybody, and welcome to this first webinar program of the Association of Surgeons of India. Our esteemed and dear President, Dr. Arvind Kumar, for 2019, has this as one of its missions to enable digital CME programs which can reach all over India as well as every corner of the globe. This is now going to be a regular feature which will be broadcast on the third Wednesday of every month between 3:30 p.m. and 5 p.m. This month's program is going to be started with the topic of an approach to massive abdominal wall hernias. And our speaker for today is Dr. H.V. Shivaram. He is the head of surgery and its allied specialties at the Digital CME Hospital in Bangalore. He is the program director for bariatric and metabolic surgery. But more importantly for us today, he is one of the leading experts in the management of ventral abdominal hernias. This is an interactive session, and while he's talking or after he has finished, you can send in your queries, your doubts, your clarifications, or even your points to improve the outcome of this program into the small chat window that you have at the side of your main screen. For those of you who would like to send in questions, there is also a WhatsApp number on which you could send a message. This number is, kindly note it down, 9632786145. Kindly give us your name and city of origin of the question. Right now, we will spend about 45 minutes listening to Dr. Shivaram on how functional restoration of the anti-abdominal wall while maintaining its retaining integrity, which gets lost when patients develop massive ventral abdominal hernias, is now dealt with in the proper recommended surgical approaches. Over to you, Dr. Shivaram.
Thank you, Dr. Rajan. Professor Rajan is a good friend and a very senior surgeon who has vast experience in all types of hernias. It's very appropriate that the Association of Surgeons of India has selected him to coordinate this CME, Digital CME today. I am aware that this program is beamed all across the country and around the globe, and the Healthium Medtech Private Limited, with which we have associated for beaming this all across, has done elaborate arrangements in many of the medical colleges and also rural areas for this digital CME to be seen, and we are very grateful to them. I am thankful to Association of Surgeons of India, specifically Dr. Arvind Kumar and all the members and the executive committee for allowing this to happen and to become a monthly feature. I am thankful to all our patients and all my colleagues of the Association of Surgeons of India and so many other associations and this local Bangalore and our own team in Digital CME hospitals. It is prudent to say that we have all learned a lot from the International Health Hernia Collaboration Group, the Abdominal Wall Reconstruction Group, and the social media, and lot of our surgeries are being shaped by the digital media these days. I'm really thankful to all of them. And the CMI Hospital, from where we are beginning this program, has provided us all the facilities, and we are thankful to them. Ladies and gentlemen, I strongly believe that the massive abdominal wall hernia is a different disease. Why? You will come to know shortly, but this cannot be managed like other abdominal wall hernias or ventral hernias. This throws challenge to the surgeons for an appropriate management, and the standard repair becomes an impossible proposition in these patients. And the laparoscopic repair, which we are all trained, may not be a good option in many of these patients. Not only that, the massive abdominal wall hernias throws a challenge to the patient also by incapacitating the patient. They may have to live with poor quality of life. Many of them come with gait abnormalities, backache, and other symptoms. And many times, if they are not managed properly, there are multiple recurrences. They have to live with this, and they lose faith in the surgery and also our pattern. Added to this, if you see many of the standard surgical textbooks, there is not much written about massive abdominal wall hernias, and our postgraduates and younger colleagues are looking up on different areas to look into this problem. So what is giant or massive ventral hernia? We can't say any standard definition is it available, but most surgeons agree that those having more than 10 centimeter defect size and along with loss of domain, they should be classified as giant or massive ventral hernias. If you do a CT scan and estimate the hernia volume and the abdominal volume, you can see that hernia volume is greater than 25% or 30% in these patients. So that's about how we say it is giant or massive hernia. Why these hernias develop in the first instance? I can cite three important reasons. The primary hernias, which are neglected for a long time, either by the patient or their family or by the surgeon with reassurance, or they are arising after one or more failed repairs, which we all do in many of the cases, or they may be arising after open abdomen or a laparoscopy. So all these patients can develop massive or giant ventral or abdominal wall hernias. The contents are often multiple bowel loops and other viscera, and these contents mostly lie outside the abdominal cavity in a sac, because once they come out, the muscles, abdominal wall muscles, retract, and what is left out is sometimes called as the second abdomen outside the main abdominal cavity. These are some of the pictures of our patients. You can see how the massive ventral hernias are incapacitating them, and recurrent hernias where we have to treat and manage very, very carefully. All these years, when we used to see all these massive hernias, we never used to think much, and most of us used to see them in the OPD and then take them and post them for surgery next day, the OT list. And once we are operating, then we used to realize, oh God, what to do now, because it doesn't go inside. and we cannot close the abdominal cavity. So we were used to do mesh repair. All of us have done mesh repair, and many times not possible. You do a onlay mesh repair or close the abdomen with tight sutures, or sometimes bridge the defect with a mesh. And many times the surgeons used to do omental or bowel resections so that the abdominal visceral contents reduces and somehow we can close the abdomen at the end of the surgery. And what was the result? And many of our patients used to go to post-operative ICU and on ventilators, and there used to be many wound issues, whether it is the skin necrosis or wound adhesions or the wound site problem, surgical site infections, and ultimately the recurrence used to be more than 50%. This is not a good scene at all. Onlay mesh repair, where you put a large mesh anterior to the rectus sheath and the external oblique muscles, sometimes we may, or most of the time we may fix it, but the problem is the intra-abdominal pressure always pushes this mesh anteriorly, and many times as the patient intra-abdominal pressure increases or becomes obese, these meshes used to be pushed out and the hernia will recur. Closing the abdomen with tension. This is what, when we were students, was taught. Put tension sutures, somehow close the abdomen, but when you put too much into a bag or a suitcase, the bag itself gets damaged. Same thing happens to our patients also. The intra-abdominal pressure rises, it causes cardiorespiratory embarrassment. The anesthetist cannot bring out and come out of these patients' anesthesia, and they go to ICU with invasive or non-invasive ventilator. If these patients come out of this problem, many of them develop the lateral recurrences. This is because of the disruption of the linea semilunaralis in these patients, where there is tight intra-abdominal pressure, the visceral contents push laterally, and you can see in this CT scan that the lateral hernias develop in many of these patients, which makes again the difficulty in the repair ultimately. So friends, what can be done as a best situation in these patients? Most important and the key to success is the pre-operative optimization of these patients. Don't be in a hurry, prepare them well in advance, and then when they are well prepared, then we should take them for an effective and elective surgery. If you see this CT scan, the small and medium hernias may not require much of optimization. But when you have a large or a giant hernia, definitely they require a pre-operative optimization in all the possible ways. Some of these patients may be smoking. We have to tell them to stop smoking for at least 8 weeks. And if the diabetic patients, if they have high HbA1c, it should be brought down to 6.5 or 7. If they have morbidly obese, whatever you do surgery, it may not hold good. So we have to, weight management is a very important issue in this morbidly obese patient. If they have any precipitating factors which cause chronic cough, constipation, urinary difficulties, all these will cause raised intra-abdominal pressure. They should be tackled before taking them up for hernia surgery. If there is a remote infection, you should control that, treat that. If there is a liver disease or ascites, they may not be good candidates for such massive ventral hernia repair surgeries. patients should start doing incentive spirometer, prepare their lungs, see their nutrition, whether it is optimized or not. And if you have a difficult patient, it's a very good idea to have a multidisciplinary team meeting where even the anesthesia specialist is also involved, so that we are all in the same line, whether intraoperatively or postoperatively, and ultimately get the best results out of this surgery. When you see these massive hernias, what we see in our eyes or what our hands can feel may not be the entire thing what we see. The devil lies in details, it is said. So we have to go into all the details, and not only a proper physical examination, but also other imaging modalities. If you see this patient, you can just see a hernia here, but that's just a small thing. We are looking at it. When you properly examine this patient by their leg raising, head raising test, and also asking them to cough, you can see what is lying behind. The entire abdomen is weak, and don't look at the patient, only the hernia, but look at the patient as a whole and manage the patient in the whole as an entire patient. Imaging is become very, very important in these patients. Ultrasound abdomen may be good enough to detect gallstones, but it is not very useful in many of the obese patients and other sick or massively weak abdominal wall patients. CT abdomen has become very, very essential in massive or giant ventral hernias, to not only to assess the defect size, but also to assess the status of the viscera. Abdominal wall musculature, very important to know where there is weak, where there are multiple hernias, and any other intra-abdominal pathology. Once the CT scan is done, we can assess much more effectively and plan for surgery very thoroughly in these patients. So I mentioned about loss of domain. What is loss of domain? This is when the more than 25% of the viscera is outside the abdominal cavity, then we have to call it as the loss of domain, which can be objectively assessed by a proper CT scan. Once there is loss of domain, the closure of abdominal fascia is either impossible after the proper mesh repair, and it can lead to high intra-abdominal pressure, as I mentioned, or may lead to facial dehiscence later, and compartment syndrome and cardiorespiratory embarrassment. So in such a situation where there is loss of domain and a very giant hernia, if the surgeon is inexperienced in handling such patients, or the center is not very well equipped to manage these patients, it's always safer to refer to a center where there are good abdominal wall reconstructive surgeons in a higher center. That's the good thing we can do for these patients who have multiple recurrences and giant hernias. This is what is known as the Tanaka index on CT scan, where you can see that the ratio of the hernia sac volume is compared to the abdominal cavity volume, which is more than 25%. We have to optimize these patients, and we cannot just push the hernia cavity contents into the abdominal cavity. So how to achieve tension-free repair and manage the loss of domain? It's the most and important, crucial aspect in all these giant hernias. So friends, as of now, we have two very powerful tools to come out of this loss of domain problems. One is the botulinum toxin or Botox injection to the abdominal wall musculature. The other one is progressive preoperative pneumoperitoneum. I will explain these two important tools in a little elaborate manner. The Botox injection to the abdominal muscles. This causes temporary flaccid paralysis of the external oblique, internal oblique, and transverse abdominis muscles, and this lasts for 6 to 9 months. So what happens when there is flaccid paralysis? There is abdominal cavity volume increases. It can hold more viscera which are there outside the abdominal cavity. It doesn't happen immediately. We have to give about 4 to 6 weeks after injecting the Botox, then taking up them for the appropriate surgery. So what's the dosage? We mix 300 units of the Botox in 150 ml of normal saline, and this makes 2 units per ml. So then, under ultrasound guidance, we can inject in the anterior axillary line on both the sides about 25 ml to each muscle. So after this, wait for 4 to 6 weeks. This increases the intra-abdominal volume and ultimately allows the midline closure. So that is about Botox injection. Many times this is combined with preoperative progressive pneumoperitoneum, or sometimes one of these two procedures may be sufficient. In the progressive pneumoperitoneum, what we do is progressively distend the abdomen with air in the outpatient department. The first step is to put an ultrasound guided catheter into the peritoneal cavity. Daily then inject air through the invalid catheter. You can use a 50 cc sterile syringe. About 800 to 1000 ml is daily injected till there is mild discomfort is felt by the patient. Then you call him again on the next day, or you can give 1 day gap, and this is done for about 2 weeks. By this, what we are doing is the abdominal cavity and increases, all the pneumatic dissection of bands and adhesions occurs. This facilitates the reinsertion of the bubble loops into the abdominal cavity. And finally, when you do the surgery, it allows a good midline closure by a mesh repair. So this is how it is done, by injecting air, simple method in the OPD. If you see here, this is the baseline CT scan. You can see contents are outside, but when we inject Botox and do the CT scan after 4 or 6 weeks, it has elongated the muscles and also the contents have reduced. Not sufficient. You have done a progressive pneumoperitoneum where you can see that all the viscera has come down, and this allows good repair of these patients. If you see these patients, so much contents which are there has all come down after the post progressive pneumoperitoneum, and when we see in the operation table, this is what you see. The contents are not there, but a huge sac is there, and this is what it achieves in about 2 to 3 weeks after progressive pneumoperitoneum. So friends, we have a great abdominal wall reconstruction movement in our country, and I can say that before this era, we always had difficulties in these patients, large defects, just go and close the hernias, everybody used to be under tension, post-op complications used to be high, and recurrences used to be very high. But after this movement, and I can call it as post-AWR surgery era, we are doing excellent optimization of these patients with all the mentioned factors what I said earlier. Many times you may do a progressive pneumoperitoneum or a buttocks, and the large defect we do nowadays the component separation technique, and then close the abdomen without any tension, and a mesh repair is a must in all these patients. ICU, rarely these patients go. Post-operative complications have become very less, and the recurrence rate is definitely less than 5% in these patients. 50% to recurrence rate to reduction to 5%, I think it's a great service to all our patients we are doing. The aim of repair in all these massive ventral hernias is to correct the abdominal weakness and not just the hernia. Moving the abdominal tissues to redistribute the abdominal muscles and then create a dynamic, durable, tension-free repair and reshape the abdominal wall. And finally, do a good midline closure with the mesh reinforcement. Why I am reinforcing that the midline closure is important? If you see our human structure, there is support everywhere, whether it is thorax, skull, or whatever it is. But in the abdominal cavity, it's the linea alba which gives all the support. So it's very important to reconstruct and strengthen this portion of the abdominal wall. The surgical options in massive ventral hernias, we have many of them, and I said it has to be done after proper optimization. The most popular is the posterior component separation, or we call it as transverse abdominis release, which can be done one side, or if it's not sufficient, we can do on both sides of the abdomen. Open is the most often done, but there are a lot of surgeons who can have the expertise and they are doing this by laparoscopic or ETEP or by the robotic methods also. The anterior component separation also is a good option in some of these patients. Whether it's open, it is more suitable to do laparoscopic anterior component separation, and some of these repairs can be done in a staged manner in the staged repair techniques. Some of our plastic surgery colleagues, they are fond of doing these things by tissue expanders or by doing flaps and free grafts. So these are the options we have in these massive ventral hernias. So this shows what we all do, the open right stopper technique. That is the retromuscular or the retrorectus mesh repair, wherein we create the retrorectus plane and then go and that's the neurovascular bundle and then see the muscles, close the posterior rectus sheath and then put an appropriate size mesh, and sometimes it can be fixed, many times may not be required to fix it, and then close the anterior rectus sheath and the skin with or without drain. So here we are placing a large mesh in a well vascularized plane. Above it goes up to xiphisternum, below it goes up to symphysis pubis, good mesh repair and low recurrence rate. The problem with this is it has a limitation that it's useful in hernias maybe up to 8 centimeters or maximum 10, but if there is loss of domain, defect size is more than 10, then it may not be a good option. So then we have to go to the component separation technique. That is the transverse abdominis release technique. This patient you can see already ready with the pre-operative pneumoperitoneum. We have not even removed the tube. This is the pre-operative CT scan or the pre-pneumoperitoneum CT scan. Progressive pneumoperitoneum has not yet been done. And you can see the large hernias in these patients. And this is the CT scan after the progressive pneumoperitoneum. You can see that all the contents have returned down to the abdominal cavity, and the sac is containing not only the air. So this patient goes to a midline laparotomy, that is the large sac, and the sac is initially dissected. Open component, posterior component separation technique, or we call it as open transverse abdominis release. Most important is to do an adequate dissection, and then sac is dissected out, all the adhesions are removed, abdominal cavity is being opened in the midline, the vertical fashion. This is a patient who had undergone previous multiple necrosectomy, pancreatic necrosectomy, and developed a massive hernia. After optimization, that's the catheter you can see, which will be removed. The catheter was put for the progressive pneumoperitoneum. This is the TAR towel, which is very important to safeguard the bowel. While we are dissecting, we should not do any enterotomy or injure the bowel. This is dissecting and creating the retrorectus plane, and that is like in the Rice-Topor technique, neurovascular bundles, nicely seen there. And then you are going to dissect the TAR plane. So this is done medial to the linea semilunaris by carefully dissecting and transecting the fibers of the transverse abdominis muscle. Patience is required and not to injure the peritoneum underneath. We can do from above below. Most of the time that is a good thing because the fibers are thicker here, and sometimes we can come from below upwards also. You can see that we are safeguarding the linea semilunaris, and then you can use a peanut or a gauze piece to dissect it out and go to the plane behind the transverse abdominis muscle. Once we release the transverse abdominis muscle, then you can go on that side to a plane of, you can go even up to the psoas muscle. You can see how carefully the fibers are released again on the other side. It's a patient where bilateral TAR is being done. Once we dissect it out, it's very important not to injure any of the neurovascular bundle, which is next to the linea semilunaris. Once this muscle is released, you can see how the defect which appeared impossible to close, and you can dissect all the medialization of the peritoneum occurs, and it will be possible to close the peritoneum without any tension. So both the sides, transverse abdominis release has been done. Above we will go up to the diaphragm, below it will be going up to the symphysis pubis retrorectus space, and this, the posterior rectus sheath is being closed with PDS sutures. Sometimes there may be tear in the peritoneum. They have to be carefully closed. Sometimes we may use an absorbable mesh like a vicryl mesh if it is closure is becoming tension, and some people have used the dual mesh also, but preferable is vicryl mesh, which is good enough for covering the viscera and in this posterior rectus sheath. This is laterally there was a tear which was being closed. Once these, there are multiple hernias actually in this patient where there was a drain set, there was a hernia. So once that is closed, measure, see how much big mesh is required, and most of these patients require at least 30 by 30 size mesh, and Healthium has promised us that they will prepare a 50 by 30 size mesh for all these patients. At present, what we are using sometimes maybe 2 meshes required in very large hernias, but it's very important to use a large mesh which covers on either side, from one side of the psoas muscle to the other side, and below from the retrosymphysis pubis area up to the diaphragm area. So this is after putting a suction drain, we are closing the anterior rectus sheath. Without the progressive pneumoperitoneum and without the transverse abdominis release technique, this would have been impossible to close in this patient. So we use all PDS sutures, not poly, and a large polypropylene mesh has been put. You can see that, and then close the midline incision. So this is how these massive ventral hernias can be managed without any tension and medialization of the tissues and muscles. So before your surgery, check that these patients, we have a good polypropylene mesh in the body. Maybe require more than one vicryl mesh or a dual mesh, suction drains. Many surgeons use skin barrier to prevent, that is prevent infections. Associate surgeon, you should have a good person along with you. General anesthesia, epidural for the pain relief post-operatively. It's a good thing to use patient warmer, prophylactic DVT prophylaxis, and the antibiotics and Polish catheter like in any major surgeries. At the end of the surgery, it's very important to see that there is no intra-abdominal compartment syndrome or tension. For that, peak pressure is a good surrogate estimation of this intra-abdominal pressure. You can ask the anesthetist to see that peak pressure is not very high. Ladies and gentlemen, this may not be possible in all our cases. Sometimes we may have to back out and do the staged repairs, especially when there are bad enterotomies or bowel obstructions. When you see these patients or gangrenous bowel or a sick patient and loss of domain, but you are not optimized these patients, or there is an emergency surgery, best is to deal with the primary problem in the first stage and do the second stage after 6 months or so, a good proper mesh repair component separation technique. What mesh to use? There are n number of meshes. The standard what is used in these cases is not ultralight or light meshes, but the medium weight or the heavy weight polypropylene meshes. Those are the very important to hold the abdominal wall in these patients. Mesh is an implant, and we should not do anything which can cause infection in these implants. We have to learn a lot from orthopedic surgeons in this line. In these cases, they use spacesuits and take every possible precautions to prevent mesh or the implant infection, and we also should take appropriate and all prophylactic measures to prevent infection and put an implant another human being. What is not to be done in these massive hernia repairs? Do not use lightweight mesh, as I said, and do not compromise on the size of the mesh. Use a wide mesh, large mesh, and sometimes may require more than one mesh. Many times, these patients coming back with after laparoscopic repair, so please do not attempt IPOM plus in these patients. That will not hold. Do not do these cases without adequate training or the mentorship, and do not combine this anterior component separation technique along with posterior component technique in the same patient. That's not a good strategy. So what will you do when you have a morbid obese patient where the BMI is more than 35, 40 or 45? Again, a staged repair is a good technique where you can first stage, you should ask the patient to lose weight. Some of them may require a bariatric surgery, and that time do not do the mesh repair or so, or a component separation in massive ventral hernias, and bring down the weight to acceptable BMI, and then do a proper component separation technique in these patients. This is what this patient had, a 126 kg, 46 BMI, and underwent a sleeve gastrectomy, and after a year, her BMI came down to 34, and then underwent a component separation for this massive hernias. Plastic and reconstructive surgeons, I said many of them use the tissue expanders in these patients and try to bring the lateral abdominal wall to the center by expanding, and then do a good midline closure with a mesh repair. If you are doing this, it's always better to take the help of the plastic and reconstructive surgeons, who are also experts in doing the claps and pre-grafts, which occasionally we may have to ask their help in covering these abdominal walls. Is paniculectomy or abdominoplasty is useful or helpful? Routinely, this is not done, but in occasional cases, it may give a functional and aesthetic benefits. But mind you that the wound complications and the deep vein thrombosis may be higher in these patients, and it's always better to take the help of the plastic surgery colleagues. Occasionally, when there are surgical site infections in these patients, we may have to give a good antibiotics after culture sensitivity and do a proper WAC dressings, which will allow the wound and the skin necrosis to heal in these patients. So, ladies and gentlemen, and my fellow surgeons, as Professor Sir Cecil Wakely has said long back in 1948, surgeon hernia repair is a community service, if you see in the true sense. A surgeon can do more for the community by operating on hernia cases and see that there is no recurrence in these patients, or the recurrence rate is very low, than he can do by operating on malignant cases. We see so many hernias, whether it's groin, ventral hernia, or massive abdominal hernias, and millions of people all over the world suffer from these, and it's a good ethical and also a moral duty for us to see that these hernias are managed and treated appropriately in all these patients. We have a great hernia Olympiad is coming, not in London or in New York. It is in our own country at Mumbai from 28th to 30th May of 2020. Great surgeons, great academics are going to happen. I am sure all of you will register and do see that what wonders can be done in all these difficult hernia surgeries. And also during our ASICON 2019, which will be held at Bhubaneswar from 18th to 21st of December of this year, many of these issues will be discussed. I am sure we all can meet, have a wonderful academic discussion of all these difficult cases and learn and benefit each other. I thank immensely the Association of Surgeons of India and the Healthium Medtech and all of you who have logged in and listened to this talk, and thank you each one of you. And Dr. Rajan is here to coordinate if there are any questions, and surely we will try to do our best between both of us. Thank you.
Thank you very much, Dr. Shivaram. That was an excellent exposition and very clearly spoken out methods to handle the large ventral abdominal hernias. I must say that this is a challenge for every surgeon. And the purpose of this webinar is to encourage a question and answer session with the speaker, Dr. Shivaram. Kindly note there is a chat box at the corner of your screens into which you could type in your questions, giving us your name and the city of origin along with the question, and it comes up on our screens and we will be able to answer it immediately. If not, you could use our WhatsApp service and WhatsApp a message to 9632786145 and send us your question and we will answer it on the show. While we wait for the questions to come in, can I just ask a few points of clarification that may help the audience who are listening? About Botox and its usefulness, what are the rough costs that it involves, please?
Botox is expensive. When we have to use 300 units of Botox, it costs approximately about 50,000 rupees, and it has to be carefully stored also and properly used. So that's why these things have to be done selectively according to the. But if you consider this expense to the hernia recurring and are on the table not able to close the abdomen properly, this is not much. So judiciously we use these methods in the appropriate patients. Otherwise, most of the time, pre-operative progressive pneumoperitoneum is sufficient in these patients.
Well, we have a question that has come up from one of our viewers, and that is Dr. Rahul from KLE Belgaum, who wants to know the exact technique of progressive pneumoperitoneum. I know you did mention it in your slides, but could you just go through that again, please? Where do you insert the catheter? How are you sure that you're not injuring adherent bowel underneath? Is there any guidance for the catheter insertion? And what is the methods by which you ensure sterility? Kindly highlight on that.
Yeah, Dr. Rahul, thank you for this question. I also didn't know this till I went into the abdominal wall reconstruction group and AWR movement. Pre-operative progressive pneumoperitoneum has been practiced since many years. we have also started recently. See, the best way is to put in the palmos point area and the left upper abdomen, as you see in this patient, because there usually not much of injury of the bowel occurs, and you cannot do this blindly. The ways which can be done is you do a laparoscopy and then put a catheter. Many of the time what we put the catheter can be a rice tube, or it can be the pigtail catheter what the interventional radiologists use. But laparoscopy may be difficult in these patients to put this. So what we do in our department is and most people do, is ultrasound guided or CT guided catheter insertion into the peritoneal cavity. By doing it using an image, you know where the bowel is there, where it is, can be inserted, and once you insert this, you can inject the air and see that it's in the peritoneal cavity and you have not injured any of the viscera in this vicinity. So to say, taking the help of the interventional radiologist is one method, and doing the laparoscopy yourself and putting the catheter is another method. And how you do it? Air is free, not like Botox, so you can use it liberally in your outpatient, taking all sterile precautions. Use a sterile 50 cc syringe, and at a time you can inject about, first day you may be injecting about 600 or 800 ml, and next day you call him to the OPD, inject about 1000 ml through this catheter, and after the insertion you can see that there is a valve mechanism here, you can close it so it doesn't come out. It stays inside the abdominal cavity. Next day when he comes, again put another 800 or 1000 ml. I have put up to 1500 ml on single day. This is done every day for 2 weeks. And then at the end of this, you do another CT scan image. Plain CT is enough, and see that whether all the viscera has gone back to the abdominal cavity or not. If it's not there, you can do it for some more days. What it does is it makes the abdominal cavity larger and the hernia sac contents go back into the abdominal cavity. The adhesiolysis occurs, the bands and all get dissected, and when you do this surgery, it becomes very nice to see that. You can see here are they seeing the photos? Yes, yes. Okay. So you can see that all the air is inside the sac, but the contents have come out into the abdominal cavity. So that's the best way to increase the abdominal cavity in these patients. I hope I have answered your question, Dr. Rahul. Dr. Rajan?
Yeah, thank you. I think that is very clear, and coming out the second time reinforces the knowledge exchange that we need about this technique. I now have Dr. Pavan Kumar from Bellary, WIMS Bellary. He thanks you for a very nice presentation, sir.
Thank you.
And his question is there any specific indication for anterior component separation versus posterior component separation?
Right. Pavan, this is again a very good question. We have experts who do anterior component separation techniques. When you do an open anterior component separation, we have to do a lot of dissection in the anterior abdominal wall. So this leads into sometimes seromas and other surgical site occurrences. So what a lot of people do is an open repair wherein the anterior component separation is done laparoscopically, either one side or other side. So you do a laparoscopic anterior component separation and then do the midline closure as in Rice-Stopper technique. And most of the time we should not combine this, but now the world is moving more towards the posterior component separation technique or the transverse abdominis release technique. So I think I have answered your question.
My own little point to add is that in our day, we had not yet gone into posterior component separation. The few big hernias that I have had to handle have done the anterior component separation. And as Dr. Shivaram has said, the extensive flap dissection of the abdominal wall did give us some delay in the primary healing of the wound. Some patches of necrosis also did come up. And so I think it is now prudent and it is correct that we use the posterior component and preserve the neurovascular bundles to the anterior abdominal wall so that you ensure good healing.
Absolutely correct. Very nice.
We have a question now from Dr. Sudhin Nag from Jabalpur in Madhya Pradesh, and he wanted again about pneumoperitoneum, progressive pneumoperitoneum. What are the contraindications and complications, if any, by this procedure?
Right. The contraindication is basically if you are not able to enter into the peritoneal cavity safely, even under the guidance of the imaging, whether it is CT scan or the ultrasound or laparoscopically. So if you are not able to put the catheter, if the abdomen is everywhere clustered with the bowel, then this may not be possible to do, and it is not good to injure the bowel just to insert these catheter. Such patients, I think the other option we have to take, which is the Botox injection, with which the muscles get flaccid paralysis for few weeks to few months, and then we will be able to close the abdominal wall. So absolute contraindication is any threat to the injury to the viscera when you are putting these catheters. Other thing he asked is
the complications.
Yeah, complications is mainly, one is any injury to the viscera when you are inserting it. After you insert it, the most important thing is you should not overdo it. Then the patient may develop cardiorespiratory embarrassment. Also, remember that if you are putting too much of these things, some of these patients may develop deep vein thrombosis. So we may have to put them onto a prophylactic dose of the DVT, and they may have to use prophylactic low molecular weight heparin. And we always tell them to walk as much as possible so that they are not going home and lying down in the bed. And none of them have developed DVT in these patients, but that is a potential threat, and also difficulty in breathing or any embarrassment to the cardiorespiratory system. These are the things which definitely we have to carefully monitor, and they should be always in touch with these patients, especially when they are OPD patients and they go home. If any problem occurs, they should immediately get back to us.
Doctor, have you had any cases of subcutaneous emphysema as a result of the air installations?
As till now, nobody had any.
Unlikely, because your planes are
intraperitoneal.
May I ask you another question on, many of the presentations of ladies in the hernia clinics is a small umbilical hernia, but associated with massive divarication, supraumbilical and intraumbilical, and giving rise to a kind of loss of domain, in that a lot of the abdominal content is very close to this bulged, divaricated recti. What would you do in such cases, doctor?
Right. This is a problem many times we discuss in our meetings also. We have a small umbilical hernia, as Dr. Rajan has mentioned, and there is a large divarication above and below. Patient is not having a hernia, but it's cosmetically troubling the patient, and there is a hernia what should not be done in these cases is not to just go and do a laparoscopic IPOM plus and just repair that small hernia, what you see there. So these patients, now we have different options. One of the options is what is known as the SCOLA, which many of our abdominal wall reconstruction surgeons are experts. Subcutaneously, you dissect a plane anterior to the rectus sheath and then midline close this one in the endoscopic method and then over that put a large mesh. So this covers both the divarication correction and also the hernia, both of them get corrected. And also cosmetically, it gives a good result in these patients. Other option is if there is a lot of massive skin, patient is cosmetically worried, is to get the help of the plastic surgeon and do a proper abdominoplasty in these patients. Apart from these two techniques, I think other methods may not be very good in these patients.
What are your port placements when you do a SCOLA laparoscopically placed?
This is a little advanced laparoscopy techniques where we have to put ports will be put in the suprapubic region because the scar is not visible in the bikini line on either side, right side, left side, two ports, and the camera port comes in the midline. So there are experts in our group. I am not very comfortable doing this as of now, but this is another good method of doing these cases which are challenging in divarication cases.
In the post-operative phase, do you recommend the continuing use of an abdominal corset or an abdominal belt after the repairs of these kind of large ventral hernias?
Absolutely. This is a good question. Actually, many of these patients, to prevent seromass and also for the good functional aesthetic these patients, many of these patients we start the abdominal binder prior to surgery itself so that they don't have the respiratory problems post-operatively when we close the abdomen and the contents go inside and post-operatively definitely from the post-operative day onwards they use these abdominal corset for about 4 to 6 weeks so that all the things settle down and then a good functional abdominal wall is ensured in these patients.
Thank you. One of the new things that I heard from you is this Tanaka index,
right,
on CT evaluation of the abdominal wall. Could you just highlight the way they calculate the hernia sac volume versus the abdominal cavity volume?
Right. This is done by the CT scan. So Tanaka has described where by doing the CT scan you can calculate what is the abdominal cavity volume and also hernia sac volume. Then you take a ratio of this. If the hernia sac volume is more than 25%, then definitely these patients require they have then we call them having a loss of domain and they require a method either Botox or progressive pneumoperitoneum or both of them to improve these abdominal cavity volume. So Tanaka index is an objective method of assessing the hernia sac volume, abdominal cavity volume, and whether they have loss of domain, and if you do the repair, whether they go for intra-abdominal compartment syndrome, all these things. So that can be a good option to do in these patients.
Thank you, Doctor. I have a question now from Dr. Syed Wahid Pasha, and his query is on the mesh. Apart from proline mesh, which mesh is preferred, he asks. Can we use a dual mesh or a titanium mesh?
Okay. These patients, I told, require a good support to the anterior abdominal wall after a proper repair. Definitely, we should not use lightweight or lightweight mesh. Titanium mesh is a good option because it gives a good strength, and also a polypropylene mesh of the medium or heavyweight mesh of the standard polypropylene meshes. And some people use the polyester mesh, but we are not very comfortable using that mesh in this situation. But if you see all over the world, the most we use is a polypropylene mesh, and some surgeons now are using the titanium mesh also, which also gives a good support in these patients. Another advantage with titanium mesh is even the viscera comes into contact or the posterior rectus sheath is not very strong, it acts as a dual mesh, it may not do any harm to the viscera in these patients. It's an advantage of the titanium mesh in these patients.
Thank you, doctor, about that meshes. Now there's another little query that has come from Dr. Godke of KLE in Belgaum, and he says, we are watching your program here, full in the presence of students. Thank you very much for the show.
Thank you very much.
There's another question from Dr. Satyan from Satyadan from Kolkata. Is the bilayer mesh more effective compared to a single layer titanium mesh?
When you say bilayer, I presume you are talking about dual mesh.
I think he means a dual mesh.
Yeah. See, dual mesh is expensive, and it is used when the viscera is in contact with the mesh. But in these posterior component separation cases, after we do the posterior layer closure, the viscera is not in touch with the mesh. So I think it is little superfluous to use the expensive dual mesh in these patients, where an inexpensive polypropylene mesh is eminently suitable in these patients. Also, you have to need a very, very large size mesh, which becomes an expensive proposition when you are using a dual mesh in these patients.
The purpose of a dual mesh is when visceral contact with bowel is anticipated, and then there seems to be an advantage in using a dual mesh. But when we have a good layer of peritoneum and posterior sheath reconstructed by the tar release that has been done, it is just necessary to give mechanical support on that repaired layer in the form of a broad sheet. Don't even have to fix the meshes, because on top of that you're going to close the midline with the anterior rectus sheath, and this is the way a single polypropylene mesh would probably be the most ideal.
Very true, very true.
Dr. Prakash has asked on the chat line, where do you keep the drains? What plane?
The drains, basically we are keeping it above the mesh, behind the anterior rectus sheath. See, you close the posterior rectus sheath, and then you put the mesh, and then you put the suction drain, and then close the anterior rectus sheath. So whatever contents are there, it drains from the component separation area and the mesh area. Sometimes, if there are a larger cavity after closing the anterior rectus sheath, then you can keep another drain in the subcutaneous area also. Otherwise, one drain may be sufficient in most of these cases.
And these drains are the standard suction drains.
Suction drains, yes.
About the rehabilitation of these patients? When can they get back to work, and when would you allow normal daily activities after a large ventral hernia repair case?
Yes, these patients, most of these patients have an epidural catheter, so the pain is not a big issue. But when you approach this, a DVT is a real threat. So we encourage them to walk on the same day evening or next day morning. Say should be up and above and walking around, and most of them will be able to take liquids next day and then gradually upgrade it to a normal diet. Once they are comfortable, they can go home and the drains will be removed maybe maximum 3 or 4 days later, and the abdominal corset will be giving the support and they can walk around, move around. But what we restrict them is not to lift heavy weights maybe for about 6 weeks or so. After that, there is no restriction. They can do all their activities and go to their walking, gym, everything, because we know that there is a large mesh which has been put into the entire abdominal wall, which gives an excellent support.
Is there any role for pre-operative bowel preparation in getting the patient ready for the surgery when there has been a large amount of loss of domain and a lot of intestine is outside the abdominal cavity? Is there any role to?
Bowel preparation is always a controversial topic. Some people swear by it, some people don't like it. I think we will leave it to the discretion of the individual surgeons. If there are plenty of adhesions, you think you have to do a lot of adhesive lysis, loaded colon is coming up. I don't see any great harm in doing a bowel preparation, or they can be on a liquid diet for 2-3 days or a mild laxative so that their bowel is empty when they're operating. A formal bowel preparation may not be required in these patients, and absolutely it is the choice of the surgeon to finally choose what is comfortable to him.
Yeah, it just must be realized that each patient's treatment has to be individualized. It is not the same preparation and the same technique that will suit all. We have to think of a patient as an individual and tailor the surgical preparation as well as the mode of surgery and the method of repair that is going to be used to fit that patient appropriately.
Absolutely, very well said. I think each patient is different, his disease is different, we have to individualize. Even the larger protocols may be same, but individualistic approach is important.
Once again, I request our viewers for any more questions. You could use the chat box at the corner of your screens or send us a WhatsApp message to the number that I had given earlier. We have about 10 minutes more before we wind up. Are we getting any queries, please? I must say that Healthium has done Healthium has done us a great favor by having this webinar method of CME available to any corner of India as well as with a global outreach, so that modern technique, contemporary surgery can be spread to everybody, can be shared with everybody in an instant hour of interaction. You save time on travel, you save a lot of other expenses that one needs to be involved in to go and train. Webinar is now going to be the method forward for CMEs. Apart from the monthly telecast of this program, which is the third Wednesday of every month, we have specifically chosen the time of 3:30 to 5 because we feel that will be the period of the day where most surgeons will be able to get themselves off their work schedules and spend a little time on this webinar. Kindly note that every third Wednesday of the month, 3:30 onwards, tune into the link that you have already used once, and you will be part of a global and national CME broadcast. The next CME will be on the 17th of July, which is the third Wednesday at 3:30 p.m. And what you have it? You have Dr. Deepraj Bandarkar from Mumbai, who will be talking on safe lap chole, how to overcome difficulties. Lap chole has now become a standard operation. Many of us are very confident of doing it, but we almost always run into cases where expertise and knowledge of local anatomy and technique are called upon to give a safe lap chole to the patient. So kindly mark the date. It is 17th of July 2019 at 3:30 p.m. on the same link that you have been tuned into today. Safe lap chole, how to overcome difficulties, by Dr. Deepraj Bandarkar, and that will come to you from Mumbai. Do we have any more questions? Any comments? Nothing. I think we'll bring this session to an end. I very, very strongly and sincerely thank Dr. Shivaram for giving us such an excellent exposition of how to go about massive ventral abdominal hernias with the loss of domain and restoring the abdominal cavity back to its domain while maintaining functional integrity of the muscles is indeed a challenge. And after listening to this session, one hopes we will have a more number of surgeons doing this competently. There is one final question that's come up on the WhatsApp. It is a question on patient having polylithiasis with large paraumbilical or incisional hernia. How to proceed with the case? He has brought in dual pathology here. Yes. Dr. Shivaram, please.
Maybe it may not be. Is it related to this massive hernias or any?
No, any. He says large paraumbilical incisional.
Okay,
we'll take it.
So many of these cases, our patients also insist that they want to get the gallbladder out and also the hernia to be repaired. So it is very important to carefully assess these patients and also do a proper counseling when you are encountering such patients. So there is, if you say that you can do a laparoscopic polycystectomy in these patients and then do a proper mesh repair, what is advocated is do not do this in an infected situation. If a patient has an acute polycystitis or an empyema gallbladder or a chronic polycystitis is there and you are doing a bile spillage or anything or the stone spillage, then do not touch the hernia or put a mesh. Just leave the hernia as it is. On the other hand, you are doing a mesh hernia repair and there is a gallbladder which has stones or symptomatic and the patient desires that a gallbladder to be removed. What is practiced in many surgeons is to remove the gallbladder laparoscopically without tying any spillage or the bile leakage and put the bag into the endobag and remove it from the epigastric port. So it doesn't come in the contact of the umbilical hernia site or the port. So it is removed to separate port. Then you decide whether this can be done laparoscopically or do a open mesh repair of these repairs. What I am telling is gauge and assess whether there is an infected situation or a threatening infection in these patients, and very, very be careful in putting a mesh in these patients, because once the foreign body gets infected, you have no choice but to remove that and complicate the situation. I hope made my points clear.
It is the dictum that you treat the symptomatic component of the patient for which he has presented first. If there is a gallbladder asking for stones to be removed and there is an incidental hernia, we need to explain to him the possibility of a staged approach for that patient and tackle the gallbladder laparoscopically, wait a few weeks or a month or two, and then repair the hernia appropriately. Trying to do both in the same situation has now been shown to have adverse effects and probably hernia recurrences and probably increased incidence of mesh infections when dual surgeries are combined. So the thinking is moving towards using separate days of operation for each pathology.
Safety first.
Yes. So I think we've come to an end of a very useful session. Once again, I thank you, Dr. Shivaram, and I also thank the Healthium team that have allowed us the webinar facility. It has been very nicely arranged over here, a nice bright room with computers and the best of technology with us. A really big thanks to the Healthium team. Thank you very much. And thank you, audience, for being with us. Good evening. Have a nice evening out and hope to see you in a month's time.
Thank you.